Have to remind me about this. Has anybody seen a tenosynovitis?
Is the decovines a tenosynovitis?
No, that's a degenerative condition again.
Okay.
No, they're actually, the synovial sheath is inflamed. Actually, it's a fasciitis, isn't it? It's a fasciosis. No, sorry, yeah, that can be. No, I'm sorry, I'm getting that mixed up with the other one in the palm. What's that?
Dupuytren's. Dupuytren's.
Yeah, bloody French, they screw me up every time. Yeah, that probably is. Most of the time it is the Quervains. Or it's a tendinitis. The thing with the synovitis though is you really can't get that from overuse. You can get a contact one where the tendon actually does get inflamed and then it inflames the synovium and then you get synovitis. But otherwise, the biggest cause of this is infection of synovitises. You have to be really careful with them because they're really difficult. First off to diagnose, and then having diagnosed it, trying to figure out what the hell's causing it. So be really careful about that. And they don't act like a tendinitis. These things don't act like that at all. On active movement, they'll get pain pretty much throughout the movement. As the tendon is moving through the sheath, then it's painful. It'll start, if you do an isometric contraction, it'll be painful when they start the contraction often, because you'll get a little bit of movement and then it'll stop. And then when you release the contraction, then you'll get pain again as the tendon moves again. So it's an on-off thing when you do an isometric. It's really peculiar. So it's not the easiest thing in the world to diagnose. Sometimes it is simple overuse, and probably what I'm saying is the tendon gets inflamed and then the synovium gets inflamed from that. Either way, you're probably not the best person to treat tendinitis or tenosynovitis, even when they're not serious, because these respond well to steroids. So why are you messing with it? It's really a waste of resources, and the treatment's simple and safe. Why not use it? If I was a physician, I'd certainly wouldn't be sending them out to the therapist. Patient ends up with weeks of rest. Okay, anything else on inflammation, degeneration that you want to talk about? Degeneration is much more interesting actually, because
Jim, just a question. For the tenosynovitis, did you say just steroids and rest is it?
Well, steroids often do it without the rest. Yeah, I mean, you should obviously stop doing stuff that's aggravating, right. But it's not a regime of rest. We're not going to put you in a splint for 6 weeks or whatever it is. The steroid should take care of it really quickly. And without much in the way of side effects. Certainly, I think if I was a physician, I would be using that rather than NSAIDs. It's quick, safer. Yeah. Even an injection probably going to help, not into the tendon or into the sheath, but a general, like a steroid, an intramuscular steroid injection. Probably going to help that as well. But I don't think I'd send it to the therapist.
Jim, quick question regarding that with the steroid injections. What are your thoughts on it if, say, you have someone who has a steroid injection, it's effective for a little while, but they consistently kind of have that pain come back? Like, does that change your thoughts on treatment approach and physio or no?
Well, no, it wouldn't have changed my thoughts anyway, because the question was, when they've got that sort of inflammation, why have they got it? So you've got, like, when you're looking for etiologies, you really are limited in what you can find. It's really interesting what we do. For biomechanical stuff, we can find etiologies that the physician has no idea are there. But when you're looking at medical conditions like inflammatory conditions, we're really limited in what we can do. So unless the patient's given you a history of doing stupid stuff, yeah, that's it as far as you're concerned. How else are you going to find out what's causing the inflammation? So if the etiology was found, then presumably something else would be going on other than just the steroids, because all that's doing is treating the side, isn't it? The symptom of the side. That's all it's doing, but not treating the cause. So if you give the steroids when you haven't found out what's causing it, it comes back, it's because you never treat the cause in the first place. Yeah. Medicine is such a goddamn boring job the way most of them do it. I don't know where they spend 8 hours a day doing this stuff. I really don't understand it. It's so goddamn boring the way it's practiced, mostly by GPs. Actually, I don't know what it's like now, but in Britain at one point, GPs had the highest suicide rate of any profession. The feeling of helplessness and boredom, I'm sure.
Is that in Canada?
That was in Britain.
Oh, okay.
Yeah, and bad pay.
Jim, can I ask another question?
Yeah, sure.
Sometimes clients come and they say, my doctor suggested a hyaluronic injection.
Yeah.
And they ask, like, would you suggest it? And I have no kind of facts and information on that. Like, what are your thoughts, like, for just to answer them?
It's like stem cell stuff. It works sometimes, it doesn't work other times. That's it. I mean, if you're looking at this or surgery, I would take that. You can always have the surgery done, but once you've had the surgery done, you can't undo it. It also depends on where they're getting it done, like stem cells. Is Canada doing that now? Stem cell injections, so they still holding back.
Yeah, they're doing. They also
If
do
you're
this
paying a
PRP.
lot of money for it, then it becomes a bigger problem. Yeah. I know a lot of Americans were going down to Mexico to get stem cells done, and it was costly. It's costly in the States anyway. Everything's expensive in the States. If you're going to pay a lot of money out on it, then the question's more critical. Should I do this? If it doesn't work, I've wasted all this money. Yeah. But if it's being done for minor or moderate costs, then it's worth trying. My wife had both knees injected, and within a year she had both knees replaced. But that's her, it's not everybody.
I don't think they're doing any stem cell here, Jim.
Sorry?
I don't think they're doing any stem cell therapies in Alberta, at least, as a,
Yeah, I don't know, I've sort of lost track.
But I've heard a lot of people going to Mexico to get it done.
Yeah, and it ain't cheap.
Yeah, and I don't know how successful it is. I have heard a couple of them successful.
Yeah,
not a whole lot.
It's really hit and miss, and I don't see. The problem is, where are the numbers on it? If it's not being done as a mainstream therapy, but nobody's actually doing much in the way of clinical research, you have no idea how good it is or how bad it is. So what I would tell them exactly that. It does work in some people from anecdotal evidence more than anything else. And in other people, it doesn't work. That's it. Your choice. If you're going to spend a lot of money on it, you may lose a lot of money. Pretty much, I think most people who need this end up having surgery anyway. Because it can only last for so long unless you're having repeated injections. Doesn't help you much, though, does it?
Jim, I have a question regarding this inflammation. If it is a traumatic inflammation and if it's a client coming to us, what is the timeline we can tell, like how long it'll take for the inflammation to settle down?
It depends an awful lot on how bad the inflammation is, how much damage has been done. Like we tend to forget that. You twist your knee and you think, oh, it's inflamed, it'll go away. You actually don't know what damage you've done there. Because when it's inflamed, clinically, it's really difficult to say what's going on there. You do all the stress tests, they're all negative, and then the inflammation goes down, and then you've got your positive tests because everything's being stabilized by the swelling. It's really difficult to say how much damage has been done, therefore how long will the inflammation last. How compliant are they? Are they on it? Are they resting it? What are they doing? What medications are they on? And what's their resistance like? You know, how good is a response is their immune system at dealing with this? Now, a lot of people, their immune system goes right over the top, and it's an excessive response to a minor injury, which is what inflammation is, isn't it? Like most of your injuries don't require inflammation. It's your body saying there's an infection there, let's go and kill it. So it's an all or nothing response, basically. Most of the time, though, when it's inflamed, it really needn't be inflamed. These minor amounts. So I don't know. I don't think there is a reasonable timeline. I would think, though, if they're doing everything right, they're resting it, not aggro. Like every time they injure it, every time they hurt it, they're causing more inflammation. So if they're doing everything right, the thing isn't swelling up. I would think probably on average, and there's no damage done, they should be looking a lot better in 2 or 3 weeks.
3 weeks.
I think if it's going on much more than about 3 or 4 weeks, then somebody needs to look at this properly. All right. Anything else then? Okay, then 4 questions, 2 tests. This is about essential illness scripts. Now, I touched on illness scripts, I think pretty much on their first go round. An illness script is a picture that you have in your mind of a condition. So we take something really simple, tennis elbow again, okay? So if you look at the essential illness script of this, it is lateral elbow pain, pain on gripping, tenderness over the tendon, isometric wrist extension is positive. Yeah. Have you got any other signs or symptoms that you want to add to that? No? Come on, you can't let me get away with this all the time. Really? Have I left anything out? Essential. No? Okay, so the thing with only 4 questions, in this case it is only 4 questions. If we ignore the first one, where's the pain? Because you've got to have something to work on, that's your start. So where's your pain? Lateral elbow. You generate a hypothesis. Tennis elbow is the obvious one because it's the most common cause of lateral elbow pain, yeah? So if you look at all the essential illness script is the minimum diagnostic criteria to diagnose the average presentation. Is that okay? So the average presentation is pretty much what I said. Lateral elbow pain, pain on wrist extension, tenderness of the tendon, and pain on gripping using the hand. Now, I then ask those questions and do those tests and see how well they fit with that essential illness script. If I get a 1-to-1 fit here, then I'm pretty sure that's what the problem is. Is that okay? Now, if you look at this, what I haven't asked them is what caused it? What work do they do? What's their leisure activities? What medications are they on? What other medical conditions do they have? Anything else you want to ask them? Your patient, you've done this a number of times now, with tennis elbow, I should think. Anything else you want to ask them? No?
Oh.
All right, so let me add something in. I have rheumatoid arthritis. Does that change the diagnosis? I'm taking, what the hell's current treatment for rheumatoid? They're doing all genetic drugs there, aren't they, for this stuff? I can't remember what they are. Anyway, I'm taking medication for rheumatoid. I've also got cancer, and I've got a family history of cancer. Does that change the diagnosis? If not, is there any point in asking those questions when you're making the diagnosis? No? I'm taking silence as acquiescence. Is that reasonable?
Yeah.
Or are you sitting there seething underneath going, so why ask them? Why ask these questions? I haven't asked them about their neck or their shoulder or their family or anything else. I've not asked them how many children they've got. I haven't asked them any of this stuff because I don't need to. It's got nothing to do with the diagnosis. The presentation that the patient's giving me is what makes the diagnosis. Is that fair enough? Okay. So all of those being positive, I can now say they have a common extensive tendinopathy. I could probably have a good stab at saying whether it's tendinitis or not tendinitis right now. But I can say that definitely this is a tendinopathy. There isn't much else that I'm going to do with that unless I make an error. All right. If I've made no errors, if I'm bias free, then that's got to be correct, doesn't it? This gets to be almost pure deduction, which is really rare if you do. If everything's done right, this becomes deductive. If you're not sure, and there's no good reason for you to be sure about this, hypothetic deduction almost never exists. Okay. Hypothetic deduction, actually, deduction is this. Deduction is a critical reasoning process, but deduction says this: if the premises to the argument are true, then that's what I'm looking for. Then the conclusion must also be true. That's deduction. The problem we have is that the premises are almost never true. So I'm relying on the patient to tell me things that are true, and they may not be true, and they may have double meanings. So deduction is really almost impossible in clinical reasoning. There are exceptions. Pathonomic deduction is true deduction. Let me think. There's not many of them, that's the trouble. The copper irises is Wolff-Wilson disease, and that only exists in Wolff-Wilson's disease. So if you see those, then that's what they got. That's true deduction. But this almost never happens. It's very rare. If you look in Wikipedia, they've got these listed out, and there's maybe 30 of them. Now, 30 amongst God knows how many thousands of conditions, and these are all rare conditions anyway. It's not very many. So we don't make deductions. You can't, because you can't get true premises. So what we do is inferences, inferential reasoning, or abductive reasoning. Abductive reasoning, sorry. It's inferential reasoning. It's not quite inductive, but it is inferential. So what you actually are doing when you do hypothetic deduction is actually hypothetic inference. But if you ask all of those questions that we talked about, all of them, family, neck, job, all this stuff, ask them all of that, then this becomes less and less likely to give you the right solution. Because it becomes too general and the sensitivity goes up, but the specificity goes down. So if you keep this to a minimum of questions and answers, then the specificity of the exam increases. So you end up almost with a deduction. If you think about this, in the absence of error, testing error and bias on my part, assuming that I'm not biased and not made a mistake, is there anything else that set of signs and symptoms can be? That is, do you have a differential diagnosis that comes close to matching that? Then we'll pull it apart. So what do you have? You must have differentials for that. No. Come on, you must have a differential. Give me a differential diagnosis for lateral elbow pain. We'll start there. Anything you like that causes lateral elbow pain. Quick.
Bursitis, oligocrinal bursitis.
Bursitis. Okay, let's pull it to pieces. Which bursa? This is how you should deal with this, actually. So which bursa on the lateral side of the elbow is going to give you pain? There isn't one, is there? So the answer to that always is it's an anomaly. All right. You can always use that. So bursitis is out. Give me another one. Another condition that's going to give you lateral elbow pain.
A lateral collateral ligament
Okay.
strain.
LC strain. You've had courses from me before, Kim. What do I respond
Strain.
with? Tear.
Strain.
Tear.
Okay.
Do you know what? I was thinking about this the other day. Somebody define strain for me. I think you can actually have strain, but somebody define it for me. You can't define it as a tear because it's a tear. Yeah. I was thinking about this the other day, and it was annoying me because there is an argument for using the term strain, and I don't like it.
Well,
Hate
I
it.
would think if there was tenderness on palpation of the ligament and then tenderness with stress testing, but you're not feeling any laxity in the stress testing, that would be an argument.
Grade 1 tear.
Okay.
If it is strain, I remember reading long time ago, it was like, if it is in the problem is in the muscle, we call it as a strain. If the problem is in the ligament, we call it as a strain.
Yeah, okay, fine. Okay, first off, strain has an engineering terminology to it. You can strain a tissue, yeah? But you really can't sprain a tissue. Well, not just a tissue, but anything. Sprain is a crap word. And why would you give a different name for something that's occurring in the muscle as to something occurring in a ligament? It's the same pathology, I would assume, isn't it? There's a disruption in the tissue. Why would you give them two different names? Because they're in two different parts of the body. I'll give you this. If I have a ligament, not a muscle now, but if I have a ligament that has been stretched out, but has no discontinuity in the structure of it, I will give you that as a sprain. So a grade 2 instability, ligamentous instability, could still be a strain. Grade 3, that's less arguable, but a grade 2 could be a strain of the ligament. If you look up strain on the online on the dictionary, they talk about, well, it's a strained joint. I mean, really, they're just arguing their point from arguing that point again. There's no real rationality saying, oh, a strained ligament is this pathology, you strain a joint. And then they turn around and say, that doesn't tell you how bad the injury is neither. So what the hell's the point of it? It's a layman's term that the orthopedic surgeons have picked up. Let's not do the same crap. Okay? We'll avoid it. But I will give a strain as there is no discontinuity in the ligament. How the hell you tell that clinically, I don't know. MRI maybe. You're probably better off calling them all tears. Okay, so onto LCL tears. If there's no history of trauma, then this clearly doesn't apply. If this is a traumatic tear, it could be a microtraumatic thing where it's been stressed out over time. Okay, so this is one possibility. Now you have to ask yourself now, why does using your hand hurt and not using your elbow? with a ligament tear. No, there's no good argument for that, really, is there? Also, why isn't it tender? Or rather, why is a tendon tender? But I can test the LCL idea by palpating the ligament. And if that's not tender, that's clearly not what it is. So you come up with there's a differential diagnosis that's reasonable for lateral elbow pain, but starts to break down. But that's okay. The idea is to test the differentials against the information you've got from the patient. That's how this works. So give me another cause of lateral elbow pain.
Yeah, radial ulnar joint dysfunction.
Okay. I'm going to shift that for the minute to radiohumeral because it's more likely to give you that type of pain, but that's okay. We'll come back to radial ulnar as well. This is the one that can throw you out. So this can hurt when you use your hand and not hurt when you use your elbow. If I've got a slight arthritis in there, this joint's inflamed, or possibly a biomechanical dysfunction, then if this isn't too bad, then I never move my elbow to the extremes of range. I mean, you just don't do it. Yeah, you're always working in that mid-range. You never do this unless you're an athlete, in which case they whine earlier. Yeah. So that's one thing that says it's probably not. The other thing that says it's probably not is the tenderness of the tendon. So using your hand can compress the radial head against the humerus and it can give you that pain. So using the hand can be painful with a radiohumeral problem. And wrist extension can be painful for exactly the same reason. So the difference between a radiohumeral problem and a common extensive tendinopathy is palpation. So this is one place where error can come in. If when I examine this, I've made my hypothesis, tennis elbow, I've gone through the illness script, I've palpated. If my palpation is poor, that I'm not doing proper layer palpation, I'm not feeling the structure that I'm actually palpating, I'm just digging my thumb in there, trying to hurt them. If I dig in too deep, hit the radial head, then that palpation can be off, and the pain's actually coming from the radiohumeral joint, but my bias now, my confirmation bias, is saying it's coming from the tendon. So this is a bias on my part, confounded by an error in testing. Okay. So that's about the closest differential diagnosis you can come to this. Radial ulnar is not as good as this, as radiohumeral, because to palpate the radial ulnar joint, you're going to have to get right in there. And this thing is much more medial than is the radiohumeral. Plus the fact you're going to have probably pronation and supination, possibly in the history, but that is also the thing they complain of, is turning the hand when they're gripping a knob or something, doorknob. But it's going to be painful when you do this. So what you're going to see there is it's a joint problem. Your passive movement is going to be negative. Your passive movements are going to be positive. Your isometrics probably going to be negative, but your palpation again is going to say what it is. It can be a ulnar-humeral joint can give you lateral elbow pain as well. So again, what you've got there is it's a joint problem, not a contractile problem. So it's going to show up on passive movements rather than contractile testing. So this is something that should always be in the back of your mind if you're not actually doing it formally. If you're not tennis elbow, we're pretty much all elbow experts in. Tennis elbow. That's pretty much what you do, isn't it? Is it or not?
Jim, I lost your voice in between.
Hmm?
We lost your voice in between, sound
Okay.
in between.
If, let's say you've got a patient walking to your clinic, they've got lateral elbow pain. Yeah. So you don't do all this stuff. You go, okay, you've got pain there. It's probably tennis elbow. Does that hurt? You push on it. Yeah. You do isometric wrist extension. Say, that's it. We're done. Is that reasonable? Is that what you do? So, man, you don't do that. What do you do?
Definitely do that, but also check the neck, like the upper scan and all, but just stuff, yeah, kind of do the other things, like is it coming from neck and all?
All right. So you're thinking possibly this is a referral from the neck.
No, not in this case right now. Yeah.
No, because it doesn't look anything like a referral from the neck. Yeah. If this is being referred from the neck, almost certainly you're going to get pain all the way down to the lateral elbow. So if you thought this is referral from the neck because of that pattern, you wouldn't be thinking this is tennis elbow. So
Yeah,
your first hypothesis would it's in the neck. Yeah. If it was coming from his shoulder down the elbow, you'd be thinking this is in the shoulder, not that it's an elbow problem.
true.
So to make the diagnosis, the neck doesn't even come into this. It's not even a consideration. And one of the problems with differential diagnosis is the way it's taught and the way textbook teach it. What they do is they'll say this condition here, and then they'll list everything that can possibly cause pain to that area of the body. That's what they do, isn't it? Which is really, it's of no value to you. How does that help you check your diagnosis? Which is what differential diagnosis is about, is checking your diagnosis. That's really all it's about. Yeah. So if you're just going to list everything that can give you pain there, that's not helping you at all. What do you care? Radiculopathy, how can that possibly look like a tennis elbow? You wouldn't mix the two up. So as a differential, it's purposeless. There's no reason for it at all. Now, you do sometimes get referred pain without local pain. It's very, very rare, but it does happen sometimes. So now, if that's, I've got lateral elbow pain, I say, okay, that's tennis elbow. Let's find out what's going to start pressing around here. Your palpation is not particularly good because you know what the problem is. This is confirmation bias again. And then you go, bang. So you've got some segmental facilitation, or if you prefer, the trigger point there. Oh, that hurts. Okay, so that's tender. Then you do the isometric test, and that is usually going to be negative. Certainly it's not positive enough for it to be tennis elbow. So right there you should be going, okay, so what makes this worse? Well, it's not gripping. It might be reading, driving, anything else, but it's not gripping with the hand. So now you come away from it. Even if you initially thought it was tennis elbow, it doesn't work out for you. So at some point or another, when everything else is failing you, all of the other differentials have failed, then you'll start looking for this as a referred pain issue. Then go looking for it. Yeah. So actually, I'm going to come back to this again, because I'm pretty sure this is exactly what you all do. You didn't do this when you first started out, but this is what you do now. Lateral elbow pain, it's a tennis elbow. Does that hurt? Yes. Does that hurt? Yes. What bothers you? Move my hands. Bang, you're away. I'm willing to bet that not many experienced therapists do a full examination for the diagnosis. Then when you start looking for what's causing it, then you can look at the neck, then you can look at the shoulder and the wrist and the thorax and everything else that may be causing the problem when the patient's not telling you what's causing the problem. Yeah. But the actual diagnosis is fairly simple. The problem with this system is it doesn't work with outliers. So if you have an unusual presentation here, then this isn't going to do it for you because they're too unusual. But to be honest with you, if it's that unusual, the chances are you're not going to get it anyway. If it looks so much like what you think it should be and it's something else, then you're not going to get it anyway, not without a lot of work. And the chances are that you'll ask somebody with more experience to try and sort it out for you. Or you'll succumb to bias. That's what it is. Know that, because they've got this. So you're anchoring on a particular diagnosis because nothing else is making sense. It's the way your brain works. But the way you get to learn outliers is through reflective experience, good quality experience, where you look back on your decisions and learn from them. And then you'll learn the outliers as well, maybe. Unless you completely miss the bloody things. And a lot of the times you treat a patient without knowing what diagnosis. Take a motor vehicle accident. If this is an acute injury, you're happy it's not fractured, but you've got an acute injury now. Can you even tell me what the damage is? What's the pathology that's gone on there? In that acute phase, you can't. There's too much going on. Everything hurts. You can't differentiate out. If you go in and feel for biomechanical dysfunction, you find one, nobody's going to say, okay, that's what's causing all this mess. It just happens to be there. Yeah. So you treat them on general principles. Let's get the inflammation down and let it rest, and then we'll have a look at it when I can have a look at it. But the first thing to do is get the pain out of the way. That way you get rid of all the reflex inhibition and so on. Get all that stuff out of the way, and then you can look at what's actually happening there. Yeah. So that's a mantra. 4 questions, 2 tests. The less questions you ask, the less tests you do, the more specific the exam is. But they've got to be the right questions and the right tests. Okay. So we're going to be dealing with biomechanical dysfunctions, almost, well, not entirely, but a large part of the peripheral course. And let me give you the illness script for a biomechanical dysfunction. This actually applies to the spine and the peripheral joints. The average presentation of this is that it's an episodic condition, short duration episodes of pain, 3 weeks at tops, 4 weeks. After that, you really have to wonder what the hell's going on. So 3 weeks followed by a longer period of non-pain. Yeah, and then you get another episode. So episodic, short duration episodes, moderate pain, moderate referral, non-obligate functional loss. They choose not to do things because they know it's going to bother them. There's a flexion or extension impairment. One movement dominates the picture. So if it's extension, for example, if we're talking about, it's a tough thing, I'm going to talk about the spine because the principle is the same, it's just more difficult. In the spine, for example, if I've got a jammed joint causing pain when I go into extension, then what I'll find is that any movement that requires extension from that joint is painful. So it'll be extension, right side bending, and one or other of the rotations. Is that okay? So you get this partial articular pattern, but it's based on extension. So the patient will tell you that these movements hurt the other movement a lot more than the other movements do. So it's dominated by flexion or extension in the spine. In the periphery, it may be dominated by flexion or extension or abduction. But one movement dominates the picture. The other one may be uncomfortable, but one is dominating it. When you look at the range of motion, though, one shows up, flexion or extension, and its related movements. Okay. And that's pretty much it. So what questions have we got here? How bad is the pain? Where is the pain? How does it come on? Is it episodic or not? Yeah. Don't care about what's causing it, but how does it come on in episodes? And then objective testing or impairment, flexion or extension impairment. And then objective testing is range of motion. Really, that's it. So they're going to capture the average. The outliers of this, though, are first episode, and then you run into trouble because this may be their first episode. They've got to have a first episode, and you may be the unlucky one to catch it. So it's the first episode, and often the first episode is a lot more severe than subsequent episodes. And if you have severe pain, then you can have more referral, because that's one of the factors in determining how much referral is going on, is the intensity of the stimulus. And then that intense stimulus can give you an obligate functional loss, and then everything hurts. So this looks like something completely different. That's the outcome. And what it looks like in the spine, for example, it's a disc herniation, but without radiculopathy. Is that okay? All right. Do you have any questions there at all? I'm going to send you some questions I want you to have a look at. It's about diagnosis. And I'm not going to give you a lot, and it's a different way of asking about diagnosis. I want you to have a go at them if you would, and we'll talk about them next time. And I'll also send you another video. Is that okay? Not too onerous, this is it? All right. Okay, guys. Nobody asked me if it's onerous for me. Nobody gives a damn about me. All right. You have a good week, and I'll talk to you next week.
Yeah. See you, Jim.
Thanks, Jim.
Take care,
Thank
everybody.
Bye. Bye.
Bye.
Bye, Jim.